Space where healing might take place, where everyone is valued. Given tools to maintain where equity matters. Less talk, more action, where anyone is welcome. Don't send them home packing, it's a strong talk. Where conversation pops off, speak life, reflect hope, promote choice and love folk. Strong talk, real talk, no jokes. Recovery, culture, community, let's go. Yeah, what's the word, what's the word? Word, strong talk, what's the word? What's the word, what's the word? Yeah. What's the word, strong talk.
Hello and welcome to Strong Talk, a podcast dedicated to the discussion of equity, diversity, and family as it relates to mental health and addictions. A space not only to talk about challenges, but to explore and to create space for solutions. I'm your host, Vic Armstrong. I want to thank you all for joining me on this journey. I'm joined today by Dr. Sosunmolu Shoyinka. Dr. Shoyinka is Chief Medical Officer at Philadelphia Department of Behavioral Health and Disability Services. He's also a board-certified psychiatrist and addiction medicine specialist with a passion for improving access to high-quality mental health treatment for underserved populations. Dr. Shoyinka, thank you for being with us today.
Thank you for having me. It's a pleasure to be here.
You are a very, very busy man. You got a lot of things going on. So I'm just going to jump right into this because I know we'll have a lot to talk about. But one of the things I have been really anxious to talk with you about is really 988. 988 has obviously come online last summer. The 3-digit number to access mental health services for people who are experiencing either a mental health or addictions crisis or who just want to reach out to someone for help. But there are still a lot of opportunities and challenges around 988. And I'm just interested to get your thoughts on where you see us being right now with 988 and maybe where you see us going with 988 going forward.
Well, thank you. Thank you for that question. And I agree with you. I think in some ways, 988 is one of the biggest innovations in the mental health field in decades. Mm-hmm. You know, the opportunity to directly connect with trained behavioral health counselors and do so uniformly across the country for all, really when it's mature, for all groups, is I think is a fantastic thing for the behavioral health field. As one might expect with any effort of this scope and scale, we're still very much in the early days, right? This is less than a year since its soft launch on July the 16th of 2022. So I think there's different jurisdictions are at different stages of implementation. One of the things that I'm happy about, certainly in Philadelphia, is that the city council has actually taken this effort on and provided a great deal of direct support in terms of funding and political will and so on. And I'm eager to see that replicated across the country, which for the most part, it appears to be the trend. I do think there has been a deliberate strategy of messaging very sort of strategically around this, with essentially Vibrant and SAMHSA encouraging a slow roll in terms of mass marketing, not so much local messaging, I think, but now mass marketing. And that's really been to allow time for, I think, jurisdictions, again, to get their feet under them, get the planning done, begin implementation. So I'm eager to see the awareness, once the mass marketing begins, hopefully this summer. I'm eager to see more awareness of this number.
Well, what you described too, at least to me, sounds a little different than what I've heard from some other states, and that's mostly what I hear is states that are putting resources and emphasis behind the 988 rollout, but Philadelphia is doing it as a city. So how does that work? Because it would be much more, I would think it would be much more local messaging as opposed to something that's brought, more broadly across the state. And a lot of the challenges, as I see for 988 would be around how you roll this out in rural areas, which, for Philadelphia, you're talking about a major city. So what does that look like when a city puts resources behind 988?
That's an excellent question. And I think you're absolutely right about um, I guess we should say local challenges, urban versus rural areas. Mm-hmm. Philadelphia had the fortune, as well as I think what was actually a tragic event that really turbocharged that effort. So we were fortunate in that the youth crisis system had already been a transformational effort around that starting 2017. So we had that template to work with. Mm-hmm. In terms of the models, the additional services, and so on that are being implemented on the adult side. We also had the fortune that planning actually had begun independently of the 988 initiative in 2019. But what really kicked it off was the very tragic shooting death of Walter Wallace by Philadelphia police when he was in the midst of a mental health crisis, and it was caught on camera. I think some people may have seen that video. Very tragic, but what it did was really unite the city around the idea that something needed to be done differently. And so the city council, along with the mayor's leadership and obviously leadership of the Department of Behavioral Health, put a full court press around implementing this effort. And I'm pleased to say that that is beginning to yield some results. More broadly across Pennsylvania, we do have, when I say we, I mean the state has a coordinated effort that is run through the Office of Mental Health and Substance Abuse Services, OMSAS, with state leads and various committees that coordinate these efforts around the state. So it's I think it's being done right in Pennsylvania. Now, the challenges persist, of course, and I would say some of the major ones, maybe the major one actually at this point, is staffing. We have a critical shortage of behavioral health trained personnel in the industry across the board. Yeah. And that is clearly impacting the ability for local jurisdictions to recruit and train staff to do the work. There's also, I think, the other issue that I mentioned earlier, which is just awareness. People don't know what is available, then they will not use it. And I should mention, apropos to your earlier comments, one of the biggest concerns is the lack of trust in Black and Brown communities. Yeah. And that is, based on historical experience. There has been, to put it quite bluntly, these communities have experienced structural racism in terms of accessing care, in terms of disproportionate use of coercive treatment at all levels when you look at the literature. And so I think there would have to be intentional and sustained efforts to work through those concerns.
Yeah, that to me kind of pivots to a larger question around access in general, partly because when I think of access, I think about not only having physical proximity to resources, but also access being resources that speak to your needs, resources that address your immediate needs, your immediate concerns. So can you talk a little bit about where we have some both challenges and opportunities around access, and where do you see us remedying some of our access issues, and maybe even more specifically in some of our more underserved areas and with historically marginalized populations?
Thank you. I think to answer that question, there's so many layers to it, right? There is what you talked about, the urban versus rural divide. We know that, for example, I think it's over 60% of US counties don't have trained behavioral health personnel. That is particularly the case in rural counties. So, that's a concern that will limit access to for everybody. The evidences from the literature suggests that individuals, when people come to get care, first of all, persons with mental health challenges or mental health issues historically experience discrimination. The literature is very clear. They don't get screened at the same rates. They die earlier from preventable, usually cardiac-related causes. And some of that is related to just broad, general, disparity in the quality of care that they receive from medical services. When you talk about Black and Brown communities in particular, this is such an issue still, because implicit bias does exist. It does impact the quality of care that people receive. It does impact, it does manifest in the way that folks from those communities are engaged. And historically, that has engendered a lack of trust. With regards to 988, some of the concerns that we've heard in Philadelphia and that the Department of Behavioral Health is working to address is what you talked about, is this need for hyper local messaging, because Philadelphia is a city of neighborhoods, and what you get in Germantown may not be the same thing as what you get in Mount Erie. People want to be engaged differently. And so one of the efforts that DBHIDS is, the Department of Behavioral Health is making, is really crafting a marketing strategy for 988. It's social marketing. So we've engaged a local marketing firm to help us listen to our communities, learn how they prefer to be communicated with, and then help us design messaging that actually speaks to them in their own language, so to speak. But we have a lot of work to do.
So where do you see things like telehealth and opportunities like that being avenues to really increasing access?
It's a good question. So telehealth what it does is it eliminates a number of barriers that one could sort of fall under the social determinants category, right? So if a mother has to decide between going to work, needing to take time off work to take her child to a medical appointment and possibly losing her wages for the day, so it's the choice between putting food on the table or attending, clinical appointment. That's an impossible choice for a lot of people.
Right.
In theoretically and actually in real time, telehealth potentially does away with some of those barriers, right? It eliminates distance, time, and so on. You can jump on a call during your lunch break, so to speak, or take an hour. It's not a perfect solution, however, because we have all heard about the digital divide, right? So certain communities do not have the ability to access broadband internet as much as we might take that for granted. That's still not a given for everybody. And so that's one potential barrier, in spite of its huge potential. The other potential barrier is something I was going to speak about earlier, which is the literature is actually pretty clear. People do better when they engage with a provider that is matched to them in terms of ethnicity and background. The literature is very clear on that. And we still don't have enough clinicians that are Black and Brown. So we have to address that issue as well.
Yeah.
So telehealth is a huge tool potentially, but there's still things we need to address.
Absolutely. And you kind of touched on something else too, because when we talk about many of the challenges and much of it may manifest itself in as mental health challenges, but a lot of it stems from trauma, and a lot of the issues, whether it is structural exclusion or racism, that sustained exposure to systemic racism and trauma, or systemic racism and complex trauma, often manifest in the mental health of Black and Brown communities. And then on top of that, we're still dealing with the effects of COVID, which in many ways exacerbated a lot of those challenges that historically marginalized communities were already dealing with. Can you speak a little bit about your thoughts on the impact of trauma and COVID on the mental health, particularly of historically marginalized communities?
Yeah, that's an excellent question and excellent point. One of the things that we've seen in Philadelphia, we track, we keep track of our data pretty closely, and so we look at population level indices. For example, we know that preceding COVID, we know that the rates of death by suicide for preteen Black youth have steadily gone up over time. Now, that is a phenomenon that has been compounded by all the various traumas that have occurred during COVID. The effects of distancing, which was necessary, during the pandemic, but obviously has led to isolation and a rise in domestic violence and so on across all populations. We also know that young females seem to be particularly challenged in terms of anxiety, self-image. Some of that is not necessarily related to COVID. Some of it, is becoming linked to social media, and so on. So we know that's a population that has been impacted as well. In large cities, we historically have not really thought about this, what I'm about to say, as trauma, but it is. If you look at redlining, the areas where redlining occurred historically, they actually map precisely onto the areas of the city where you have the greatest socio-economic challenges. So poverty, schooling, jobs, even gun violence maps very clearly onto those same areas. So these are problems that were created, or maybe I should say worsened by historical marginalization. And I also talked about, now the other area where trauma happens, which we don't think about, and I'll talk about how it manifests in a minute, is and this is one of the reasons why I'm excited about 988, when people have called for help historically, they've been responded to by law enforcement. Now, obviously, there have been efforts over the years and I want to say this very carefully, with all due respect to law enforcement, who I know have made efforts over the years to learn about responding to people with behavioral health needs, with things like CIT. Even with that, oftentimes those communities have experienced things like over-policing and so on within those neighborhoods. And so think about it, somebody in a mental health crisis calls for help, and the response that comes to them is something that's associated with trauma. When you think about the additional layers that oftentimes happen, when a person calls for help, police show up, they get placed in handcuffs and transported at the back of a wagon. So that's somebody who's oftentimes having the worst day of their life, and we've just our systemic response has not made it better. If anything, it's made it worse. And so one of the things that we're working hard to do in Philadelphia is to the extent possible, ensure that a behavioral health crisis is responded to by behavioral health personnel, which includes things like expanding our mobile team capacity, includes training our crisis call center staff, includes actually embedding crisis call center 988 staff within the police radio room, so that at the point of calling, if it's identified as a behavioral health call, it just gets routed directly away. One other thing I didn't mention has been talking about trauma, is how it manifests, right? So many kids are diagnosed with things like ADHD, conduct disorder, that are not, that are actually those are actually manifestations of trauma.
Mm-hmm.
A kid who already has been traumatized or raised in an environment where they're exposed to multiple adverse childhood experiences will manifest very differently. And we have often punished those behaviors by sending them, the school to prison pipeline, excluding them from school, applying highly coercive or restrictive treatment to them.
Yeah, yeah. And speaking of that, I know as we're trying to think about all the ways that trauma manifests and thinking about the impact of trauma on mental health, it can be a lot for people to understand, especially how it shows up in Black and Brown communities, because it can look different. But that also leads me to one of the final things I want to talk to you about. You have a book coming out soon on, and I believe the title of it is actually Understanding Mental Health. Can you talk a little bit about what we can expect from that book?
Thank you. Yes, that book was written actually with a particular population in mind. Now, the material in it the book is titled Understanding Mental Health, A Guide for Faith Communities. It was written with, obviously, the material in it will speak to everyone, because it's the, understanding of mental health conditions, the biology of them, and how they manifest and how they're treated is the core material. But it's also written with the understanding in mind that many people, particularly within Black and Brown communities, will first go seek help from their religious communities.
Yeah.
And that oftentimes when they do go to seek help, the understanding of mental health conditions, what they are, how they manifest, and how they're treated is oftentimes not as robust as one would hope for. And so this book is really a tool to educate those communities and position people to respond appropriately.
Yeah, that's a book that I'm definitely going to want to read. A lot of the work I do is also work with the faith community, and I think one of the challenges that I often see with the faith community is it's often difficult for them to really marry theology and mental health together, and they see them as really being counterintuitive, and that's not necessarily the case. But getting them to see that, oftentimes I think what they lack is a tool, a resource to help them to understand how to have those conversations and then what mental health challenges can look like. So I'm really looking forward to that. And believe it or not, we are about running out of time here. So I want to wrap it up, but I do want to give you an opportunity. You shared so much with us today. Is there anything that you'd like to share with the audience that you haven't had a chance to share yet as we begin to close out?
Yeah, thank you for the opportunity. The book will be out in early May the 2nd, and I can provide that information to you at the right later on. Yeah, the things I would like to say is basically this: is mental health concerns are real. For those who may still sort of be ambivalent about the idea that these conditions are real, they are real. Their cost is enormous. It's enormous for the individual suffering. It's enormous for their families, and it's enormous for all of us as a society. The good news is that there is help, and the help does work. It actually does work.
Mm-hmm.
I often refer people to a New York Times article from, I think it's 2011. It's called Lives Restored. It talks about everyday people in a different sort of backgrounds and so on who have experienced these conditions, some very severe, and were able to come back from them and live normal lives. So that's the core message here, is that there is hope. There is hope. There's help and there's hope.
That's a perfect note to end on. Thank you so much for sharing. And thank you, Dr. Shoyinka, for being my guest today. And thank you to all who tuned in today for Strong Talk. We'll see you next time. One area that often goes ignored by men is mental health. While statistically, men are nearly 4 times more likely to die by suicide than women. Men, in fact, account for almost 70% of all suicides. And this trend is proof that men need to start taking their mental health more seriously. There are a multitude of stressors facing men that contribute to or exacerbate mental health challenges. Financial stressors, supporting a family, and juggling a career are just a few of the day-to-day challenges that can affect a man's mood. The additional stressor of keeping a facade of strength and not talking about those issues only makes the problem worse. There are also additional stressors that impact men of color, including the intersection of stigma regarding mental illness and the impact of health disparities and systemic racism. Lack of access to community mental health resources and treatment modalities that take into account the nuances of race and culture make it more likely that for men of color, the introduction to the mental health system is far too often in the back of a police car. It's time to normalize men speaking up about their mental health and to create safe spaces where men can voice their feelings without judgment. These spaces break down the stigma surrounding men and their feelings and mean fewer men must suffer in silence. Talking about mental health puts men in a vulnerable position, which is understandably uncomfortable and often feels unnatural to a man who's been told all his life that sharing feelings indicates weakness, which is unbecoming. The key is teaching men to identify, understand, and respond to signs of mental illness and to recognize that there is no weakness in acknowledging a need for help. To do this, men need safe spaces, low-pressure environments where they can open up to people they know and trust. In the best-case scenario, the safe space starts at home with loved ones, spouses, and partners asking the men in their lives how they are feeling and recommending seeking help if there appears to be a persistent issue. Show that you're there, you're present, you're non-judgmental, and you're willing to help them through whatever they might be going through. Changing the way men engage with their emotions is a crucial first step in terms of turning around these numbers. Opening up about our feelings and seeking out effective care is essential if we as men are going to live our lives to the fullest. As men, we owe it not only to those we love, but also to ourselves to be the best version of ourselves that we can be. There's no value or valor in suffering alone in silence. As men, it is time for us to be vocal, be vulnerable, and be visible as we create space for healing. And that is Strong Talk.
What's the word? What's the word? Word, strong talk, strong talk. What's the word? What's the word? What's the word? Yeah. What's the word? Strong talk, strong talk.